Good afternoon, dear audience. I'm going to talk about the recent progress of my PhD research on the diagnostic and therapeutic options in sepsis and trauma-associated coagulopathy. My name is Tímea Mátyási-Dombi. I'm a PhD student and a specialist in anesthesia and intensive care, currently working in Manningerjenő Trauma Center, Budapest. My vision is to see efficient hemostasis management worldwide. Therefore, I would like to improve the personalized hemostasis management for critically ill patients. Currently, I have two ongoing projects. Both of them use the method of meta-analysis. First, I investigate the efficacy and safety profile of thrombomodulin in sepsis-associated coagulopathy. Sepsis disrupts the balance of hemostasis in up to every second cases, causing the formation of microthrombi, leading to different organ dysfunctions and even death in every second case. Thrombomodulin, an anticoagulant agent with anti-inflammatory and antifibrinolytic activity, so it can be a potential therapy target in sepsis treatment. However, the recent sepsis guidelines are controversial, while the latest Japanese sepsis guideline recommends thrombomodulin, the International Surviving Sepsis Guideline doesn't include it. So our aim is to investigate the possible clinical benefits of thrombomodulin in treating sepsis-associated coagulopathy. This led us to our clinical question: does thrombomodulin therapy improve the survival rate of patients with sepsis-associated coagulopathy? We used this PICO framework, comparing thrombomodulin versus standard of care. We investigated primary outcome mortality and different secondary clinical outcomes. After a systematic search and selection process, we have found 34 eligible articles for our study. The first investigated outcome was 28-day mortality. We had more than 8,000 patients. The overall effect of thrombomodulin was 0.65, which means that the odds ratio of death decreased by 1/3. This is a clinically and statistically significant result. We have analyzed non-randomized propensity score-matched observational studies and randomized controlled trials separately as well. The biggest effect was in the observational group, where the odds ratio of death decreased by half. In the propensity score-matched group, it was around 30%, and in the RCT group, it was around 15%. These latter two cases, it is not statistically significant, but there is a strong tendency to reduce mortality here as well, so we should definitely consider thrombomodulin therapy in sepsis. There was an even remarkable effect in the intensive care unit mortality, where this effect was even half. So the mortality decreased to half in intensive care mortality in intensive care patients. The severity of coagulopathy can be measured by different DIC scores. For our investigation, we used the Japanese score to quantify our measurements. Comparing the different studies, we didn't find any baseline differences in DIC scores. But after 6 days of therapy, of thrombomodulin therapy, we can see that the DIC score was 1 point lower in the thrombomodulin group. It is mathematically significant and clinically relevant as well, because it translates to the resolution of coagulopathy. which was almost 4 times higher in the thrombomodeling group compared to the control group. And after the resolution, we can expect that organ dysfunction will improve. That's why we have checked the SOFA scores. SOFA score is to evaluate the patient organ functions. The more the scores, the more severe the patient is, and there will be elevation in mortalities as well. Comparing the 2 groups, there were no difference in the baseline SOFA scores, but after thrombomodeling therapy, the organ dysfunction improved in the thrombomodeling group significantly. To assess a specific organ function, we checked ventilatory-free days within 28 days, where we found that thrombomodeling patients needed less ventilation compared to the control group. And less ventilation is clinically relevant because it leads to less complications, for example, infections. Regarding our safety outcome, we compared the bleeding rate, and during thrombomodeling therapy and after thrombomodeling therapy, we found no significant difference in bleeding rates. The RCTs, non-randomized studies, were evaluated separately, and we had more than 8,000 patients for 5 primary outcomes. These were the strengths of our study. But there are, unfortunately, limitations, like there were a limited number of RCTs. These were mostly Japanese studies, and there are potential overlap of the patients in the registry analysis. So we conclude that the resolution of coagulopathy induced by thrombomodeling leads to better organ functions and reduces mortality in sepsis-associated coagulopathy patients. We may refine guidelines for thrombomodeling use in septic coagulopathy, and we should definitely plan a multi-center RCT for a specific patient population. In the summer, we assessed the risk of bias assessment and the grade assessment. We have almost finished the manuscript, and we are going to send it to internal review, and after plan to submit it to a D1 journal, Intensive Care Medicine. My second project is about the efficacy and safety of early fibrinogen supplementation in patients with severe trauma. The leading cause of mortality among young people is a massive trauma injury, and this bleeding can be even worsened by trauma-induced coagulopathy. The fibrinogen level worsens and cause different organ dysfunctions and even deaths. According to the latest European trauma guideline, fibrinogen levels should be maintained about 1.5 gram per liter in massive trauma patients. It can be achieved by fibrinogen concentrate, and it is also used in the trauma field or in the ambulance before arriving the hospital, but we are unsure about the approximate dose and the timing of this. So we plan to investigate the potential benefit of early administration of fibrinogen in patients with severe trauma. Our clinical question is, does early administration of fibrinogen improve survival in severe trauma patients? This is our PICO framework, and a preliminary research was done. And after topic feasibility check, we plan to register to Prospero and continue our work. I'm going to continue my BOSS project and finish the first one by December 2024. I would like to end my presentation with the words of our famous painter, Tivadar Csontváry Koszka. Every person needs a broader perspective to see more and to be aware of the divine nature in a broader perspective, we find a new perspective. In a new perspective, we find a new life. Thank you for your attention.
Thanks for interesting presentation. I see the painter was in Mostar, I assume, when the bridge was still standing. Now, any questions from the audience? Then I'll start. So you presented the data as they are, and there is a clear difference between different types of studies. You also elaborated a bit on the reasons for that. So I don't think you have the potential to influence the guidelines at this moment, because randomized trials and propensity score matched are showing different thing than the observational ones. Any additional explanations for that? Because sepsis for me is still a mixed bag of various etiologies. And are there any studies focusing on COVID? Because that could be potentially relevant, because we'll see COVID 1, 2, 3 or something like COVID in the future.
There are some studies, and actually this is not my field of research. It can be similar, but this is a different etiology. So I would like to focus on the sepsis and maybe different infection source of sepsis, because there are studies which implicate that it is also relevant, but we need more RCTs to see more results, more evidence-based results, because as you saw, there were not so many RCTs, and that's the main problem.
Yes, there is one question in the third row. No? No question? Okay. Anybody from the panel?
I already wanted to ask this when Adolf presented his presentation, that when you finish your, when you have a research implication comment, and this is more RCTs are needed, that drives me crazy, I must say. So, and when you say high quality RCTs are needed, what do we mean by that? What does it mean? Of course we need high quality, but if you were to design a trial, what would you make differently? So what is your problem with the current RCTs? How should we improve them? What is your opinion on that?
As I told, I would like to plan an RCT with specific infection source. There are studies where we see, for example, for abdominal infections, maybe thrombomodulin is better than in lung infections, but we need more and more well-designed RCTs. Yeah, more homogeneous group.